Ελλάδα και μάλιστα λειτουργεί αδιαλείπτως, έτσι, για 30 χρόνια. Λοιπόν, έχετε το λόγο, κυρία Καραμούντζου.
Καλημέρα σας. Ονομάζομαι Γεωργία Καραμούντζου, εκ μέρους της Siemens Healthineers. Είμαι ακτινοφυσικός και portfolio sales professional. Αρχικά θα θέλαμε να σας ευχαριστήσουμε για την πρόσκληση, καθώς είναι τιμή μας που βρισκόμαστε σήμερα εδώ. Το θέμα της σημερινής παρουσίασης είναι τεχνικές μείωσης δόσης στη διαγνωστική και επεμβατική ακτινολογία. Η εταιρεία Siemens Healthineers είναι μια εταιρεία που εδώ και δεκαετίες καινοτομεί στον χώρο της ιατρικής απεικόνησης. Ευρύτατο είναι το φάσμα απεικονιστικών συστημάτων το οποίο διαθέτει, όπως στις ακτίνες Χ, μαστογράφους, ακτινοσκοπικά συστήματα και ακτινογραφικά συστήματα, αξονικούς τομογράφους, μαγνητικούς τομογράφους, ενώ στην επεμβατική ακτινολογία διαθέτουμε αγκιογράφους, στεφανιογράφους και συστήματα επεμβάσεων. Τέλος, στον τομέα της πυρηνικής ιατρικής διαθέτουμε συστήματα SPECT, SPECT-CT και PET-CT. Το πορτφόλιό μας αναπτύσσεται διαρκώς με έξυπνες τεχνολογίες. Σκοπό έχουν την καλύτερη δυνατή απεικόνηση. Και αυτό γιατί ο γιατρός θα πρέπει να λαμβάνει κλινικές αποφάσεις με την απαραίτητη αυτοπεποίθηση. Γνωρίζετε πολύ καλύτερα από όλους πως η χρήση ιοντίζουσας ακτινοβολίας πρέπει να εφαρμόζεται με βέλτιστες πρακτικές σύμφωνα με την αρχή της βελτιστοποίησης. Ποιες είναι αυτές? Η αλάρα, as low as reasonably achievable, υψηλή ακρίβεια και επαναληψιμότητα, ασφάλεια τόσο στους ασθενείς όσο και στους εργαζομένους, τα οποία αυτά πρέπει να είναι στάνταρ για κάθε σύστημα. Στη διάγνωση και την θεραπεία του ασθενούς πρέπει να έχουμε τη βέλτιστη ακρίβεια. Ποιο όμως είναι το διακύβευμα σε όλο αυτό? Το διακύβευμα σε όλο αυτό είναι η χρυσή τομή μεταξύ της ποιότητας της εικόνας καθώς και της μείωσης δόσης ακτινοβολίας τόσο για τους ασθενείς όσο και για τους εργαζομένους. Χαρακτηριστικό μέγεθος της χρυσής αυτής τομής είναι η απόδοση της δόσης, η οποία ισούται με τον λόγο της ποιότητας της εικόνας προς τη δόση. Όλες οι τεχνικές ακολούθως που θα σας αναφέρω έχουν σκοπό να διατηρούν σταθερά την ποιότητα της εικόνας υψηλά με τη χαμηλότερη δυνατή δόση. Αυτό αποσκοπεί στη βέλτιστη απόδοση της δόσης. Ας ξεκινήσουμε λοιπόν με τις τεχνολογίες που αφορούν τα ακτινολογικά και ακτινοσκοπικά συστήματα. Μια βασική λειτουργία της Siemens, η οποία αναπτύσσεται διαρκώς από το 1994, είναι το CARE. Το CARE προέρχεται από τα αρχικά των λέξεων Combined Applications to Reduce Exposures. Σε αυτό, μεταξύ άλλων, περιλαμβάνονται για τα ακτινοσκοπικά συστήματα τα εξής. Το Snapshot Mode, το οποίο τι είναι? Είναι εικόνα στιγμιότυπου, η οποία δημιουργείται από το άθροισμα πολλών εικόνων ακτινοσκόπησης, αυτόματα και αποθηκεύεται. Πού στοχεύει? Στη μειωμένη δόση. Γιατί έχουμε μειωμένη δόση? Γιατί δεν χρειάζονται πρόσθετες ακτινοβολήσεις για περαιτέρω τεκμηρίωση. Στη συνέχεια διαθέτεται το Digital Zoom. Ψηφιακή μεγέθυνση πραγματοποιείται σε πραγματικό χρόνο χωρίς να έχουμε περαιτέρω αύξηση της δόσης. Όχι αύξηση της δόσης σημαίνει μειωμένη ακτινοβολία και έτσι υπάρχει, ενώ συγχρόνως υπάρχει η δυνατότητα εναλλαγής για 4 στάδια. Περιλαμβάνεται επίσης το histogram-based dose regulation, όπου για τον υπολογισμό της δόσης χρησιμοποιούνται πληροφορίες ιστογράμματος από ολόκληρη την περιοχή της εικόνας, με αποτέλεσμα να έχουμε σταθερά υψηλή ποιότητα εικόνας. Τέλος, έχουμε το Proactive Fluoroloop. Οι αλληλουχίες ακτινοσκόπησης αποθηκεύονται αυτόματα. Έχουν σκοπό τον λόγο τεκμηρίωσης. Τι σημαίνει αυτό? Αποτρέπουμε περιττές επαναλήψεις, άρα συμβάλλει στη μείωση της δόσης. MyExam 3D κάμερα. Η MyExam 3D κάμερα χρησιμοποιείται στα ακτινοσκοπικά συστήματα και προσφέρει ισοκεντρική τοποθέτηση του ασθενούς βασισμένη στην τεχνητή νοημοσύνη. Μεταξύ άλλων, περιέχει το Virtual Collimation και το Smart Virtual Ortho. Πού αποσκοπούν αυτά? Τι κάνουν αυτά πρώτα? Αυτά διαμορφώνουν κατάλληλα τα διαφράγματα. Πώς όμως αυτό συμβάλλει στη μείωση της δόσης? Κατάλληλη διαμόρφωση των διαφραγμάτων, η οποία πραγματοποιείται αυτόματα, σημαίνει ότι έχω τόσο ακτινοβολούμενο πεδίο όσο χρειάζεται. Ούτε περισσότερο, ούτε λιγότερο. Άρα, στο μεγαλύτερο ακτινοβολούμενο πεδίο θα είχα περισσότερη δόση. Στο μικρότερο ακτινοβολούμενο πεδίο θα είχα μικρότερη δόση. Το μικρότερο ενέχει τον κίνδυνο να μου διαφύγουν ανατομικές περιοχές τις οποίες θα ήθελα να απεικονίσω. Άρα, μπορεί να πραγματοποιηθεί επανάληψη της ακτινοβόλησης. Να σημειωθεί πως η My Exam 3D κάμερα ανιχνεύει και τις κινήσεις του ασθενούς, ώστε να αποφεύγονται περαιτέρω επαναλήψεις. Γενικά, στις ακτινολογικές εξετάσεις, οι ασθενείς επωφελούνται από περαιτέρω μείωση της δόσης με τη χρήση επίπεδων ανιχνευτών ιωδιούχου και σίου, βελτιστοποιημένα graphical organ programs, χρήση παιδιατρικών πρωτοκόλων, επιλογές διαφόρων φίλτρων χαλκού, ενώ μεμονωμένα μπορούν να πραγματοποιηθούν εξετάσεις με αφαίρεση του αντιδιοικητικού διαφράγματος για περαιτέρω μείωση της δόσης. Στη συνέχεια θα μεταφερθούμε στα συστήματα της μαστογραφίας. Η χαμηλή δόση ακτινοβολίας είναι υψής της σημασίας, ενώ η ποιότητα της εικόνας είναι το κλειδί για τον εντοπισμό της παραμικρής λεπτομέρειας. Η Siemens αντιμετώπισε αυτή την πρόκληση με την τεχνολογία Prime. Πρόκειται για τον πρώτο παγκοσμίως έξυπνο αλγόριθμο, ο οποίος επιτρέπει την απόκτηση εικόνας χωρίς να είναι απαραίτητη η χρήση αντιδιαχυτικών διαφραγμάτων. Τι έχουμε σαν αποτέλεσμα? Μείωση της δόσης έως και 30%. Συνδυαστικά τώρα, το ΑΕΚ με το OP-dose ελαχιστοποιούν την έκθεση ακτινοβολίας για κάθε εξεταζόμενο, με δεδομένη την υψηλή ποιότητα και σταθερή ποιότητα εικόνας. Το OP-dose είναι αυτό που, ανάλογα με το πάχος του μαστού και την πυκνότητά του, καθορίζει παραμέτρους έκθεσης, επιλέγοντας τον καλύτερο συνδυασμό ανόδου φίλτρου. Το OP-com τώρα με τη σειρά του επιτυγχάνει βέλτιστη συμπίωση του μαστού. Το OP-com συμπιέζει το μαστό τόσο ώστε να είναι μαλακός και εύκαμπτος. Η συμπίεση σταματά αυτόματα. Έτσι, επιτυγχάνεται καλύτερη αντιστάθμιση μεταξύ ποιότητας εικόνας και δυσφορίας. Αποφεύγοντας τη δυσφορία στον ασθενή, σημαίνει ότι αποφεύγουμε ενδεχόμενη κίνηση αυτού, επομένως δεν χρειάζεται επαναληπτική εξέταση. Θα περάσουμε τώρα στην αξονική τομογραφία, όπου η Siemens είναι γνωστή για τις καινοτομίες της. Για τους αξονικούς τομογράφους, η τεχνολογία CARE περιλαμβάνει το CARE-KV, όπου έχουμε αυτόματη προσαρμογή της τάσης της λιχνίας, ανάλογα με το μέγεθος του ασθενούς και την κλινική περίπτωση. Το X-CARE, όπου έχουμε προστασία ευαίσθητων περιφερειακών οργάνων, με χαρακτηριστικό παράδειγμα τους φαλκούς οφθαλμών και τους μαστούς, ενώ ταυτόχρονα διατηρείται η ποιότητα της εικόνας και σταθερό το μέσο CDTI Vol. Το CARE-Child, όπου έχουμε παραμέτρους σάρωσης για τα παιδιά. Το CARE-Dose 4D, όπου βελτιστοποιείται αυτόματα η κατανομή της δόσης, προσφέροντας ειδικές καμπύλες διαμόρφωσης αυτής. Και τέλος, το CARE Filter, όπου έχουμε αυτόματα διάφορες επιλογές φίλτρων. Κατά τη διάρκεια μιας βιοψίας στους αξονικούς τομογράφους, απαιτείται συνεχής καθοδήγηση της βελόνας. Η λειτουργία Hand Care αποτρέπει την απευθείας έκθεση σε ακτινοβολία των χεριών του ιατρού. Ποιο είναι το αποτέλεσμα αυτού? Αποτέλεσμα αυτού είναι η μείωση απευθείας έκθεσης ακτινοβολίας στα χέρια του ιατρού έως και 70%, ενώ ταυτόχρονα η μείωση δόσης στους ασθενείς φτάνει το 30%. Η iSpiral τεχνική, μέσω του Adaptive Dose Shield, προσφέρει πρόσθετα κινητά collimator. Διαμορφώνονται δυναμικά ώστε να σταματούν το overbeaming. Αποφεύγεται κατ' επέκταση η δόση ακτινοβολίας στον ασθενή, η οποία δεν συμβάλλει στον σχηματισμό της εικόνας. Sapphire είναι ένας Iterative Image Reconstruction αλγόριθμος, ο οποίος μειώνει το θόρυβο της εικόνας, επιτυγχάνοντας μείωση της δόσης έως και 60%, με ταυτόχρονη διατήρηση της ποιότητας της εικόνας. Ένα βήμα παραπάνω είναι ο αλγόριθμος Admire. Είναι αλγόριθμος ανακατασκευής τελευταίας τεχνολογίας, συμβάλλοντας στην κλινική εικόνα με υψηλότερο sharpness και μειώνοντας τα artifacts. Μία καινοτομία της Siemens στους αξονικούς τομογράφους είναι η χρήση του φίλτρου κασίτερου. Χρησιμοποιείται για non-contrast απεικονίσεις, χρησιμοποιείται επιπλέον του υπάρχοντος φίλτρου και είναι προς επιλογή. Το φίλτρο κασίτερου χαρακτηρίζεται ως beam hardening filtration γιατί σκληραίνει τη δέσμη. Πώς το καταφέρνει αυτό? Στενότερο φάσμα ακτινοβολίας με λιγότερα φωτόνια χαμηλών ενεργειών. Άρα έχουμε μέση ενέργεια υψηλή. Χαρακτηριστικό παράδειγμα εφαρμογής αυτού είναι οι low dose εξετάσεις του πνεύμονα, όπου έχουμε απεικόνιση του πνευμονικού παρεγχήματος σε αξονικές τομογραφίες χαμηλής δόσης των 70 kV, ισοδύναμες αυτές των 100. Ο κασίτερος χρησιμοποιείται επίσης συνδυαστικά με το χρυσό για απεικονίσεις διπλής ενέργειας. Σκοπός, ο φασματικός διαχωρισμός. Κατ' επέκταση, έχουμε καλύτερο διαχωρισμό των δομών. Σε αντίθεση με τον κασίτερο, ο χρυσός εξασθενεί τα φωτόνια υψηλών ενεργειών, άρα απλώνει το φάσμα. Όπως και τα ακτινολογικά συστήματα, έτσι και στους αξονικούς τομογράφους γίνεται χρήση Fast 3D κάμερας, η οποία επιτρέπει την ισοκεντρική τοποθέτηση του ασθενούς. Ανιχνευτές Stellar. Τελευταία λέξη της τεχνολογίας αποτελούν οι ανιχνευτές Stellar, οι οποίοι έχουν υψηλή κβαντική απόδοση και μειωμένο ηλεκτρονικό θόρυβο. Γιατί? Γιατί αυξάνεται η πυκνότητα των καναλιών και αποτελούνται από 3D anti-scatter collimators. Όλοι οι ανιχνευτές αξονικής τομογραφίας έως σήμερα αποτελούνται από μία συστοιχία φωτοδιόδου. Άρα έχουμε τη δημιουργία σπινθυρισμών. Το παραγόμενο φως συμβάλλει στον ηλεκτρονικό θόρυβο, ενώ το ηλεκτρικό σήμα είναι αυτό που τελικά μετράμε για την παραγωγή της εικόνας. Ξεχάστε όμως ό,τι γνωρίζατε μέχρι τώρα. Ένας τελείως διαφορετικός ανιχνευτής είναι πλέον διαθέσιμος, ο οποίος έχει υψηλή κβαντική απόδοση. Ποιο είναι το πλεονέκτημα αυτού? Δεν υφίσταται πλέον το σπινθυρισμός. Πώς συμβαίνει αυτό? Αντί για φωτοδιόδους που έχουμε μέχρι σήμερα, πλέον μπορούμε να κάνουμε χρήση κρυστάλλων. Τι διαφορετικό έχουν αυτοί οι κρύσταλλοι? Είναι πολύ καινούργοι και πολύ σύνθετοι, με αποτέλεσμα να έχουμε μείωση του ηλεκτρονικού θορύβου. Όλη αυτή η κβαντική πληροφορία ενσωματώνεται στον άετομ α, το οποίο αλλάζει τα δεδομένα της αξονικής τομογραφίας παγκοσμίως. Είμαστε περήφανοι στη Siemens για αυτή την πρωτοπόρα τεχνολογία, καθώς επιτυγχάνουμε ποιότητα εικόνας υψηλότερης ανάλυσης. Βλέπουμε δομές τις οποίες παλιότερα δεν μπορούσαμε να δούμε, ενώ ταυτόχρονα μπορούμε να διατηρήσουμε χαμηλά τα επίπεδα της δόσης. Εδώ χαρακτηριστικά βλέπετε μία εικόνα από σπλαχνικό κρανίο με resolution 0,2 mm, ενώ συγχρόνως η δόση έχει διατηρηθεί σε πολύ χαμηλά επίπεδα. Συγκεκριμένα, το CDTI vol είναι 5,42 mg. Για όσους δεν γνωρίζουν, η τιμή αυτή είναι περίπου 10 φορές κάτω από τα διαγνωστικά επίπεδα αναφοράς. Ας περάσουμε τώρα στην επεμβατική ακτινολογία. Ως γνωστόν, οι δόσεις ακτινοβολίας που λαμβάνουν τόσο οι ασθενείς όσο και το προσωπικό είναι πολύ μεγάλη. Για το λόγο αυτό, επιδιώκουμε να τους προστατεύουμε στο βέλτιστο βαθμό, διατηρώντας ταυτόχρονα την ποιότητα εικόνας υψηλή. Το ΑΕΚ είναι ζωτικής σημασίας για τη διατήρηση υψηλής ποιότητας εικόνας και μείωση της δόσης του ασθενούς στα ευλόγως εφικτά όρια βάσει αρχή της Σαλάρα. Έχουμε λοιπόν αυτόματα και σε πραγματικό χρόνο προσαρμογή των ακόλουθων 5 παραμέτρων. Το ρεύμα της λιχνίας, χρόνος έκθεσης, εστιακό μέγεθος, φίλτρο και τάση λιχνίας. Το εστιακό μέγεθος ρυθμίζεται αυτόματα βάσει γωνιακής κλίσης του ΣΕΑΡΜ για υψηλότερη χωρική ανάλυση. Συγχρόνως έχουμε χαμηλότερη δόση εισόδου στον ασθενή. Επιπλέον, το φίλτρο χαλκού ρυθμίζεται και αυτό αυτόματα βάσει της γωνιακής κλίσης. Optic. Η έκθεση ακτινοβολίας ρυθμίζεται με βάση την αναλογία αντίθεσης προς θόρυβο, γνωστό ως CNR. Παρέχει Material Specific Imaging, το οποίο αποσκοπεί στο γρήγορο και εύκολο roadmap στη ροή εργασίας. Το Optic είναι ένας self-adjusting αλγόριθμος προσαρμοσμένος στις ανάγκες του εκάστοτε ιατρού. Αντισταθμίζει κυρίως την κίνηση, με αποτέλεσμα να βελτιώνεται η απεικόνηση κινούμενων αγγείων και οδηγών σειρμάτων κατά τη διάρκεια της ακτινοσκόπησης. Η Siemens ενισχύει το dose efficiency συνδυάζοντας το Optic με τους πυλώνες του CARE. Πάμε να δούμε ποιοι είναι αυτοί για την επεμβατική ακτινολογία. CARE Position. Επιτρέπει την τοποθέτηση του ασθενούς χωρίς χρήση ακτινοβολίας. CARE Vision. Μπορούμε να έχουμε μείωση της δόσης έως 75%. Μέσα από μία ευρεία γκάμα παλμών έχουμε τη δυνατότητα επιλογής. Συνολικά 9 επιλογές. CARE Filter. Έχουμε δυνατότητα μείωσης της δόσης έως 50%. Η επιλογή των φίλτρων χαλκού συνολικά είναι 5. Οι επιλογές στα φίλτρα. CARE Profile. Το CARE Profile ρυθμίζει τους collimator χωρίς να ακτινοβοληθεί ο εξεταζόμενος και ο εργαζόμενος κατ' επέκταση και ρύθμιση του φίλτρου. Αυτό γίνεται βάσει δυνατότητας Last Image Hold. Low Dose Acquisition. Έχουμε δυνατότητα μείωσης της δόσης έως 67%. Το Low Dose Acquisition είναι πρωτόκολλα χαμηλής δόσης. Low Dose Single Dynasty T. Έχουμε δυνατότητα μείωσης της δόσης έως 72%. Αλγοριθμικά, τρισδιάστατη απεικόνηση. CARE Watch. Real-time παρουσίαση της δόσης. CARE Max. Ένας ενσωματωμένος θάλαμος ιονισμού με TRAD-up. CARE Guard. Έχουμε έλεγχο της δόσης εισόδου του ασθενούς. CARE Monitor. Παρακολούθηση δόσης εισόδου του ασθενούς. Και τέλος, το CARE Report, όπου μας δίνει πληροφορίες για τη δόση από την εξέταση που μόλις πραγματοποιήθηκε. Γνωστό σε όλους Dose Report. Το κλειδί, όπως έχει προαναφερθεί αρκετές φορές σήμερα, είναι η βέλτιστη ποιότητα εικόνας με τη χαμηλότερη δυνατή δόση. Άλλος ένας συνδυασμός που πραγματοποιούμε είναι το CARE με την τεχνολογία CLEAR. Κατ' επέκταση έχουμε μείωση της δόσης και καθαρές εικόνες. Τέλος, η Siemens διαθέτει την πλατφόρμα TeamPlay. Εντός αυτού, πέρα των υπολείπων, συμπεριλαμβάνονται το TeamPlay Dose και το X-Ray Dashboard. Αυτά δίνουν τη δυνατότητα για εύκολη πρόσβαση, επισκόπηση και διαχείριση της δόσης σε όλο το εύρος των απεικονιστικών συστημάτων. Πού βοηθάει αυτό? Στη διευκόλυνση της συμμόρφωσης της δόσης με τα εθνικά επίπεδα αναφοράς. Σε αυτό το σημείο θα ήθελα να σας ευχαριστήσω για την προσοχή σας.
Λοιπόν, για να κρατήσουμε το μοτίβο και της προηγούμενης συνεδρίας, μπορείτε να καθίσετε εδώ και στο τέλος και των 3 ομιλητών να απευθυνθούν ερωτήσεις στις οποίες θα απαντήσετε. Ακολουθεί ο κύριος... The next speaker is Dr. Kotsi. Please forgive me if the pronunciation is not correct. Who is going to speak about CBCT-based adaptive therapy from a clinical perspective.
So good morning, everyone, and it's a pleasure and an honor for me to be here today and to report to you about some early results and some clinical experience about the cone beam CT-based adaptive therapy. Oops. Break move. Mouse. Oh, this one. Okay, perfect. Thank you. Okay, great. So in the next 20-25 minutes, I will tell you about what I define as adaptive therapy. I will briefly introduce the ethos therapy system because most of the clinical results are, of course, based on the technical aspects of the device. And I will focus mostly on the user and the evidence that we have collected so far. So what about the definition? I'd like to refer to adaptive as a need or a process that provides in a closed loop the way to modify the plan and to refine the treatment conditions according to the daily anatomical variations and conditions of the patient. And this is in comparison to the baseline plan that is designed at the initial phase of the treatment. This is a very broad definition, but it can be applied in general. So clearly, the primary objective of adaptive therapy is to preserve the plan quality, and the secondary objectives can be focused on the possibility to take advantage of the tumor response during the treatment and or to include some planning strategies that can minimize the toxicity of the treatments for the organs at risk or to enable some other dose escalation processes. So this is the very general statement. Then what are the bases of this? The bases are the possibility to acquire daily anatomy information for the patient. So there are different options. It can be MR-based, it can be kilovoltage imaging based, and I will focus in this lecture on the kilovoltage cone beam CT image acquisition. So this is the key point. The process requires that you generate a plan, then you have the daily condition of the patient, and then you have to adapt the plan on these conditions. So the quality of the image, the possibility to acquire images, segment the images with the sufficient accuracy and precision are the key factors to exploit the adaptive therapy process with this type of images. So I will focus also a bit on the image quality aspects. So the platform, because most of the technology, the clinical results depend on the technology implementation. So the variant commercial solution is called Ethos, and essentially it's based on a ring-based delivery system with a dual-layer MLC with 5 millimeters resolution, a single beam of 6 megavolt flattening filter free, and it's a system that is suited for IMRT and VMAT delivery, and the entire adaptive process is based on IMRT or VMAT. And key factor is incorporating a fast kilovoltage imaging device for high quality cone beam CT. So this is what is the background from a technology point of view. Now, having defined the frame in general, what could be the clinical investigation point or the hypothesis that we want to explore in terms of research? And essentially, can we take benefit from the possibility to see the daily anatomy in terms of toxicity? For example, can we reduce the margins? Or can we escalate the dose because we can protect the organs at risk? Can we, at the very basics, guarantee the daily PTV coverage, because this is even more important, is the preservation of the quality of the plan? And can we eventually also look at new ways to improve the workflow and the treatment efficiency for both of the clinics and the patients? So these are high-level hypotheses and potential benefits that have to be translated into the practice. And there are, of course, a number of say, objectives or objectives that are derived from these primary goals. For example, the frequency of adaptation. How frequently do we need to modify the plan? Is it daily or less? Can we use kind of also adaptive dose prescription schemes? What are the issues of quality assurance? I will not be able to cover all of these, but I will here and there point to some of the elements. So let's start from the very first fundamental point, that is the image quality, because KV-based cone beam CT is the factor that enables the entire process. So there are some data published in literature. This is, for example, coming from the first groups. There were University of Pennsylvania, Washington University, and a few others who explored the comparison of the new imager capabilities against standard KV imaging and standard planning imaging capabilities. And here you can see that there is a, sorry, I was hoping to point to the laser. Okay, there are clear this is the laser, thanks. There are clear differences in terms of image quality between the standard KV and the new detector. New that is already old, I will speak very quickly on this. But this was the promise in the beginning. From a qualitative point of view, the images were looking ways better. And this is just the introductory element. The second is, can we define the anatomy of the day on this type of images? So are they sufficient to segment and to generate the basis for the plan of the day? So there are few studies that has been exploring this topic. I will report only about one very important study that has been carried out in Australia by the ICON network of clinics, one of the very first users of ETOS. They made a study on 18 total patients, 12 retrospective and 6 prospective patients, and they analyzed a number of about 400 sessions, half simulated and half actually treated. And the study focused on prostate, but the messaging here is to be intended on a more general, say, meaning. What they have analyzed was, based on the image of the day, the system has an AI-informed methodology to segment the image set and to generate the organs at risk. And from the organs at risk, selecting the most important called influencers, and these influencers define the deformation map to deform the target volumes from the planning to the day. So there is a process, all automated, but essentially it's based on the possibility to have a good segmentation of the anatomy. So they analyzed their data and they divided the results in terms of how frequently or how intensive was the need of editing the organs at risk, defined the influencers, so the ones defining the deformation of the target. And you can see here from the graph that they had a very small number of cases where they had the need of extensive editing, that is the only residual fraction. In the vast majority of the cases, either no editing or what they called minor editing, which means small corrections on a small number of CT slices. Then they looked at the target as deformed and regenerated from the images of the day, and the message was even more important. The vast majority of the patients required no edits at all, or only very minor edit, and some residual factors were observed on the organs that are those relevant but not influencing directly the shape of the target. And depending on the complexity of the target organ, there were some cases where significant editing was required, for example, for the sigmoid, whereas for other structures there were no editing necessary. So this is a very comprehensive study, but just to point to the result that even in the beginning, the images were good enough to generate anatomies of the days that required a minimal intervention and were suitable for the further steps of the daily replanning. But can we improve? Technology can evolve, and a new detector has been introduced and released recently. It is commercially called HyperSight, but the key factor, it is a wide surface panel with double the size in one dimension compared to the standard detector, and as a fast acquisition mode, the rotation can operate at 6 RPM. There are filters implemented in the acquisition. It corrects automatically with Accurus for the scattering of the patient, and many other factors, which brings to a higher image quality. Very important, an accuracy in the Hounsfield unit of the same level of the planning CT, and as I mentioned, the acquisition within 6 seconds. Is this changing the way we are looking to adaptive therapy? This is very new, so investigation is ongoing, but few hints can be already derived from the clinics. For example, these are images from the prostate. This is the planning CT, this is the normal cone beam CT on ethos, old-fashioned, and this is the new model with HyperSight. And you can see that there is a significant noise reduction and some further increase in the say, contrast resolution. This is similar for the lung with the contrast CT, a cone beam CT, or an Accurus. And again, you can have reduced artifacts, better definition of the shape of your volumes, and more certainty about the position of all the structures. Next step, having a super fast acquisition, can we consider to deliver even the treatments in say, freezed setting, so in breath hold essentially? Because if you can acquire images in 6 seconds, you can imagine also to deliver the treatments in a few seconds or using breath hold as the methodology. So the basics is breath hold imaging introducing some benefit again in the definition of the anatomies of the days? This is an ongoing study at the Nova Scotia clinic in Canada, where they are comparing HyperSight images in breath hold with free breathing, with normal true beam, or a fan beam CT, so the planning CT available in breath hold. And you can clearly see that there is a very significant say correlation between these two image sets, whereas you're losing plenty of resolution, you're adding a lot of artifacts due to the breathing motion if you are not using this approach. This is in the abdomen. This is an image set taken from the thorax, so the messaging is the same. So, investigation question, but appears to be practical, that if we can acquire these images in breath hold, then we can segment in breath hold, and then we will be able to treat in breath hold. Remember, the machine acquires at 6 RPM, delivers at 2.5-ish RPMs, so there is probably the need of more cycles of breath hold, but this is a path that is clearly observed in the clinic for the evolution of the approach. And what about Hounsfield unit accuracy? Because I mentioned this as another interesting feature. So this is the comparison between the planning CT and the HyperSight cone beam CT, and this is a profile along the dashed line of the Hounsfield units. You see that there is a perfect match between the two lines, and the discrepancy between the Hounsfield units between the two sets is minimal. There is more than this. This is just the example. There are systematic studies that has been done, certification with all the standard procedures, determination of the Hounsfield unit variation, etc. But the key message is that there is a very good correlation between the say standard planning and the new cone beam CT. This brings to the possibility to perform the plan directly on the cone beam CT of the day. And we can even see later clinical applications where we are thinking, or clinics are thinking about treating the same day treatment of the patients without the need of going through the process of the normal planning with the dedicated CT scan, etc. So this is a new research, say, opportunity and pathway that is opening. So far about imaging. The final message is that imaging is there, cone beam CT, KV based, seems to be perfectly suitable for the adaptive strategy. Now, is the pudding tasting well and good and sweet or not? We have all the ingredients, let's see how it tastes. So first of all, do we have to treat the scheduled or the adapted plan? Let's put again back on the table the study performed by the ICON group in Australia, but the data are consistent throughout the clinics. In their study, they ended up with more than 95%, essentially 98 or plus, of the fractions that should have been treated or were treated in the prospective patients with the daily adapted plan. And this is the frequency that has been done in a very comprehensive study. But if you look at the data collected from all the machines installed in the world, you see that the situation is not too far from that. The current situation is that about 87 to 90% of the fractions are treated with the daily adapted plan. This is a confirmation that the quality of the images is good, and the confirmation that there is a clear advantage in treating the daily plan. But what is this benefit? Can we quantify it? I think this image should be sufficient to justify the need of daily adaptive. This is the typical conference image where the situation is macroscopic and it is so simple to see the advantage. But in general, there are very frequent situations which are maybe less evident than this, but dosimetrically very relevant and clinically meaningful. And can we try to quantify again this type of advantage? Once more back to the ICON study, because this is the most comprehensive we have today, where they quantified the number of dosimetric dose volume constraints or clinical objectives that were improved or worsened by using the adaptive daily or the conventional, let's say, baseline plan. And 0 means no advantage, so you see that the curve is biased. The blue and orange means the retrospective or prospective. And it means that you have a significant benefit, and the number of clinical goals that can be improved is large on a very significant number of fractions. And you can improve up to 4 or 5 dosimetric endpoints on a very large number of fractions. So this is another direct confirmation that the daily adaptive approach increases the quality of our plans and meets the primary goal that we outlined. What about margins? This is the experience from the Rikshospitalet in Copenhagen, again, one of the very first centers. They are running an in-house trial on bladder, multicentric with a couple of other centers. But what they did was to start from the standard IGRT margins. Then after a while, they collected ethos-specific margins from their population, and you see already that there is a reduction of the margins that they were feeling needed because of the imaging process and the better definition of the anatomy of the day. And then finally, they moved to a patient individualized margin set that is defined in this way. The first week of treatment, it is now with the ethos adaptive margins. Then at the 5th day, there is a review process offline, taking the decision from the clinicians, and from that day on, the patient can be treated with the individualized, personalized margin. And the CTV definition is modified dynamically from the image, but the PTV is rule-based, and the margin is defined in the automatic AI system. So reducing the margins has clearly a huge potential for toxicity and all other stuff. So this so far for the benefit. What else? Well, we have to generate evidence, so we need clinical trials. What is ongoing today? What are the research directions that are followed at the moment? Varian, as a company, is sponsoring a number of trials on adaptive treatments based on the KV cone-beam CT imaging, and these trials are listed here, are covering different sites and different indications: head and neck, lung, pancreas, bladder, and prostate, and in different settings. Some centers are treating with normal conventional fractionation, some trials are with hypofractionation, and they are essentially all multicentric. Some of them are randomized, otherwise they are matching the data against historical controls. They are all prospective, and they are accruing, ongoing accrual is of more than 1,000 patients. So this will be a significant amount of data that will be collected over the next couple of years. But this is the variant-directed research. There is also another flavor and another direction of investigation, that is what is coming from the investigators on the local institutes. And there are a number of trials that has been financed but not sponsored, so the research program is entirely on the institutional side, checking and doing research on a number of topics and a number of different treatment sites, but with the general aim to investigate the role of margin reduction, the possibility to explore biological response and to adapt onto biological response, the possibility to introduce multimodality imaging in the control of the process, but also in the definition of the adaptive schemes, escalation of the dose, and what I mentioned before, the seamless or same-day treatment options, which are extremely important in the workflow management. So, approaching the end, what is, say, unlocking, what are the unlocked opportunities of research? I would say that we are seeing a strong interest in the usage of hyperfractionation and SBRT in general, but applied to adaptive therapy, this becomes more and more important. If you treat 3 times, you have much less chances to make errors. If you think about pancreas trial, the pancreas trial is 5 fractions of 10 grays per fraction. It's pretty aggressive. It's, for example, at Humanitas, we are not treating like that. We consider it too aggressive for the technology we have today, but these are the trends, and there is a huge interest in that direction. And the second is the seamless. So what about the usage of, say, stereotactical treatments? If we limit to the ethos utilization, so the centers having the opportunity, we are collecting data that shows that about 84% of the patients treated with adaptive therapy are treated in some kind of SBRT regimen, whereas this is not the case for the normal treatments. But much more interesting is the second approach, is the, say, expansion of the treatment options to the acceleration of the treatment per se. So reducing the gap from the, say, enrollment of the patient in the clinic up to the first day of treatment, and to explore how adaptive therapy can play a significant role here. So there are several strategies that can be explored, but the key element that is under investigation today is to perform seamless treatments. This is an abstract that was presented by the Romford Institute in the UK, where essentially they used diagnostic CT images to define a generic rule for the plan, essentially the beam geometry and the clinical goals, and then to perform the real treatment planning based on the cone-beam CT of the day, doing the segmentation, the target propagation, and the optimization on the couch. The paper was presented based on the old cone-beam CT, but the study for both the Romford and the other center I will be speaking in a minute will be now continued on the hyper side. And I want to close with the FastMed trial that is coming from the Amsterdam University, where they made a very extensive program of palliative treatments, particularly for bone metastases, and their approach was to reduce the time needed to treat the patients from few days from, say, information and treatment to few hours, and to perform the entire process using diagnostic images, at the moment CT, but in the future also MR only, and to complete the treatment in few hours. They published the first results on the Green Journal, and they will now present at Astro the results of the first 100 patients. So I cannot disclose too much about this trial because the results are still going to be published, but from data that has been published and presented already at conferences, what is very important and very relevant is that in their workflow, everything starts from a telephone consultation where the clinics is informed that there is a palliative patient needed the treatment that takes about 15 minutes, and then at that point of time, the planning starts on any kind of cone beam CT from the clinics, maximum 4 weeks old. In the meantime, the patients arrive to the hospital, or it is already hospitalized, and can go directly to the ETOS machine for the treatment. And the total time that was observed for the patients spent at the department was 85 minutes on 47 cases treated in the paper, and the range was between, say, 50 minutes to a little more than 2 hours. And the standard reference for the routine procedures was about 340 minutes. So if you compare the two, there is a huge advantage for the entire team, the clinic, the patient, and the health system in general. So these are the main directions, but not all. Just to summarize, we are accelerating the development of AI segmentation tools because these are really needed for the daily. We are accelerating the development of automated planning tools because these are important to be fast at the treatment couch. The entire process has to last few minutes in total, let's say between 15 and 20 minutes for the entire session. We are exploring, and we see research in the development of different adaptation rules, also offline adaptive for head and neck, for example, changes in the workflow, multimodality imaging, and not trivial, we are observing in many different areas in different countries with different regulations an elevation and an upskill process of the people at the machine, so the therapists in general terms, that are typically not exposed to so sophisticated treatments, very quickly are learning and very quickly are becoming independent in the process. And this is also very important educational stuff that will be a key factor for the success of the entire adaptive story in general. So, okay, thank you for your attention. This was all from my side.
Thank you so much. Dear Luca, that was a comprehensive lecture, and it was impressive in several aspects. We're going to have a discussion at the end of this session, but in any case, I have had the permission for one only comment. It seems that our work will change dramatically next decades.
Yes.
So we need the dedication of the clinician in the machine for the IGRT, and then there is a learning curve for the system, for the new procedure, but also there is a reflection in the clinical practice. So these are two aspects that I may ask you to discuss it at the end of this session, if you don't mind.
Yes, absolutely.
Thank you so much, and thank you.
Should I sit there?
Please, please. So at this session, we have the second part now about how artificial intelligence solution design can improve user adoption. So I introduce you Dr. Francis, which is the science manager of EMEA, and he is going to give us a talk about this new AI solution. Please.
Thank you for the introduction. Hi everyone, and thank you for attending this presentation. So my name is Dr. Francis. I'm channel manager at Gleamer. And in today's presentation, I would like to discuss a topic that is really important, but often forgotten and not really talked about. And it's how the user experience and the user interface can actually impact your adoption of AI solutions. I would like to start the presentation by first showing you the first solution we have developed at Gleamer. It's called Bone View Trauma that can detect fractures on X-rays. And here you see the first design we offered our users. As you can tell, the way Gleamer integrates into your workflow is by sending DICOM secondary captures into the existing PACS viewer. Those DICOM secondary captures are first a summary table summarizing what the AI has found, and then you get duplicates of your views showing you where the fractures are located. What we offered our users first is 4 types of results. First result, if the AI is confident that the finding is indeed a fracture, it will show it with a solid line box. Then if the AI has a doubt around this fracture, it will show it with a dashed line box. Then if the AI is negative, it did not find anything, it will simply send no fracture. And finally, not available in case we could not process all the images. Our scope of application back then was some sort of how limited to what we can do today, because we were only covering the fractures and effusions on the limbs and the pelvis only. But from the very first beginning, we understood the importance of having AI not only for adults, but also for pediatric reading. And that was the Gleamer experience back then. First, the users were getting the native images untouched by the AI. Almost a minute later, they'll get the summary table indicating if a fracture was detected or not. But it also has a quality check report showing how many images the AI has received and how many images it analyzed. And then you get your duplicates of views, and as you can see here, the AI has identified 2 fractures, for example. One is confident, you see with the solid line, while the other one is less confident with a dashed line. So when looking at those results, many of you might think this is a really simple, straightforward solution to adapt, and that is correct. It was really simple to use. But others might also think this is not the most user-friendly solution out there as well. And we do agree to certain extents, because what we're sending back, for example, is a white line on a grayscale image. So we got some feedback from our users that they were finding it hard to identify it in some cases. What we also got as feedback is the summary table. It is simple, but there's a lot of sentences that do not actually bring a lot of information or useful information for the radiologist. So we took all those feedbacks for almost 2 years with our users and also worked internally with the head of design and made huge improvement on our solution. Before I show you the new solution that we have, I would like to discuss the famous idea of evolution of blueprint ideas. How in all the fields today, all the products, all solutions, we start with an idea, and then once we put it in the hands of the users, we can have unexpected transformation to actually fit what the user needs today. And this brings me to the famous picture. I'm pretty sure many of you have seen it on LinkedIn before, where we see 2 pathways. The first one is the initial path that the designers have designed for the users to take or the people to walk on to get to the other side of the road, while the user experience set a complete different path where the people were more comfortable taking this pathway. In this situation, you need to adapt and make changes to fit the user's expectation. All while making those changes, you should always keep in mind as well not to prioritize aesthetics over usability. And this brings the famous Google example, for example, as you can see. The initial logos of Google were clear to each application what it does. While Google made some improvements, they wanted to focus only on the colors of Google, and those new logos do not tell much about the application if we did not have background information. Same thing could be applied in our fields. When we wanted to make those improvements on our solution, we thought about great ideas, or what we thought were great ideas actually. We wanted to provide overlays and heat maps. But then we noticed that if we're going to provide those results, it requires additional clicks for our users. And whoever says more clicks means less usage. I don't think anyone here wants additional clicks in their workflow today. We also thought about providing additional information to process, like the confidence score. But is it really a useful information to have on your exam? And how do you actually compare a 52% chance of a fracture versus a 72% chance, for example? In some cases, the 52 might be a true positive, while the 72 might be a false positive. Taking all those ideas into consideration and the feedback, we were able to provide a comprehensive solutions to our users today. We were able to provide visual support in the PACS and their viewer, making it a more user-friendly solution, an easier-to-adapt solution, but also providing a workflow optimization thanks to some specific features. For example, the work list prioritization feature that can prioritize any exam based on the AI result. So the users can start with the positive ones and leave the negative ones for later, for example. We also offer pre-fed report to get some gain time in reporting. We also extended our scope not to only cover the fractures and effusions, but we also wanted to cover the bone lesions, the dislocations on all the body parts below the neck, so the limbs, the pelvis, thoracic lumbar spine, as well as the rib cage. And we maintained, of course, the importance of having the AI for pediatric. And today, this is our new improved Gleamer experience. First, the users get the native images untouched by the AI. Then they'll get this summary report, which is a bit prettier than the previous one that we saw. We decided also to focus on color coding to associate the yellow one for the positive, the blue one for the negative. And as you can tell, from the top you see if it's positive or negative. The quality check report, it's easier to read as well. And we're providing additional information that is useful for our users by telling them what the AI has found. For in this example, it has found a fracture, and what it looked for and did not find. So our users can also have an idea what to expect in the exam. And here you can see the new bounding boxes we're offering, which is relying on the yellow color. It's easier to attract your attention and to locate it faster as well. With this experience of developing BoneView, we also were able to develop our second solution, which is for an AI companion for chest x-rays called ChestView. And in this solution, we were able from the very first release provide our users a visual support in the viewer and the workflow optimization. We also, thanks to our key opinion site leaders, decided with pathologies to focus on, because we wanted to provide the most important ones, such as the pneumothorax, the consolidation, the masses, the nodules, and the effusion as well. We also wanted to cover all type of acquisition to make sure that we're covering all the activity when it comes to chest x-ray. And the user experience is pretty similar as BoneView as well. First, you get the native images untouched by the AI. Then you'll get your summary table, which is exactly the same as the previous one. And this is how all of our users were comfortable using any AI solution we're developing today, because they have the same user experience. They're comfortable with the solution. They're comfortable with the results. As you can see, you have the positive on top as well, the quality check report, and also the pathologies that were identified and the ones that were not identified. Then you get your bounding boxes surrounding the pathologies that were found by the AI on the different views. We also had a request from several sites that they needed a solution that will help them on the MSK measurements, for example, and that's why we developed bone measurements. To develop this solution, we rolled out a survey for over 100 sites asking what do they actually need today in those measurements, and we were able to roll out 26 measurements that were considered the most impactful ones. We're also sending DICOM secondary captures and the PACS viewer, and the results are pretty simple to read. Based on the view, the AI will automatically compute the measurements, indicating the reference points, the measurements that were computed, as well giving a small table below naming the measurements that were computed by the AI. So it does not require any clicks from the radiologist. Only he gets the results as a DICOM secondary captures in the PACS viewer already. Last solution that was asked us also to develop is for bone age assessment, and it's called Bone Age. This is a request from a lot of pediatric hospitals actually, where they needed a solution to help them save time on this assessment. And the way it works is based on the Grealish and Pyle Atlas, and it's similar to bone measurements. The result that you're gonna get is a DICOM secondary capture as well, showing you the AI-based age, comparing it to the chronological age of the toddler. Taking all of this into conclusion, I would say our experience at Gleamer so far has been successful thanks to our close work with medical experts, where we have 6 specialized radiologists working at Gleamer. We work with more than 20 key opinion sites all over the world. We also have a strong customer success process, always gathering feedback from our users to understand what they actually need and what they expect from an AI solution to do today. All of this under the regulatory team, always supervising our activities to make sure we can provide those solutions to be used in clinical routine and to get the correct clearance, we're able today at Gleamer to provide faster adoption and faster release processes. We offer today 4 major releases per year, making huge improvement on our solution and changes. And then we do 8 minor releases, making some small changes, improvements, some small color changes, for example, that was requested by our users. All of this have led the users to be comfortable with the AI, to even shorten the trial period, where our users today, as soon as they use our solution, are comfortable with the result that they are receiving and understand the benefits behind it. Of course, all of this increasing our users' satisfaction. Just a small introduction about Gleamer really fast of our successful journey from 2017 so far. We had a massive adoption, more than 700 clinical sites using our solution in clinical routine all over the world. We process today more than 12 million exams per year. That's almost 1 million a month. All of our solutions are always CE marked and FDA cleared to make sure we get the right clearance. And we are cleared in 37 countries. All of this have led us to become what we wanted to become initially from the very first beginning of Gleamer, is an AI factory producing top-notch solutions to help our users go faster and improve efficiency as well. Today we have 10 AI products in the roadmap. It takes us, thanks to our experience and to our team, 15 months from getting the idea to providing the users the solution in clinical routine. All of this under the scientific recognition, of course. We have major publications, always peer-reviewed, approved, and published. We have 2 in radiology for now, and we also won the Alexander Mogil's Award at RSNA for Best Paper in 2022. This slide is to make your IT team happy, because they're always complaining about new solutions to include in your hospitals. And the way we work is pretty simple. It's actually one simple integration into your environment that can give you access to all of the solutions that we develop. It's thanks to a virtual machine that will automatically pick up the exams from the PACS, send them to the cloud for processing, and push back the results into the existing viewer. Thank you.
Thank you so much for your nice speech today. Please join with us, and I think that it's high time now to have our discussion. Do we have any questions from the audience, please?
Yes, thank you very much for those interesting presentations. I have a question for the adaptive system of ethos. If I understand well, today the way you make the decision of adaptation is based on the daily fraction, right? You are not doing any kind of dose accumulation. You just look on the difference between the current anatomy and what was planned on this session. And the related question is, what is usually the duration of an adaptation process?
Okay, so I got the first question, I missed a bit the second, but for the first question, you're right, the process is based on the imaging and on the anatomy and then on the planning of the day. So that is the decision that is made. Dose accumulation is offline. There are possibility to generate trends and to see the evolution of your clinical aims and objectives over time. And this is also, say, possible to inform the decision for the following days. But the process is on the information of the day. I missed your second question. The threshold, you mean?
No, the duration. How much time does it take?
The duration. Yeah, that's an excellent question. I completely missed it. So there are 3 phases, essentially. The image acquisition, that is, in the old system, it's 1 minute, more or less. With the HyperSight, is 6 seconds plus the processing, so let's say less than 1 minute. Then there is the AI component of the generation of the structures. This is again order of 1 minute, but then there is the phase of validation, and this depends. The routine cases can be 2-3 minutes. The very complicated cases can be longer. If you are in a trial, if it is in the beginning of your experience, the data that has been reported ranges from few minutes to maybe a quarter of an hour. This is very variable on the complexity. In the immediate, the next session is, or step is the plan generation, and it depends. If it is an IMRT plan, it's super fast because the fluence-based optimization on GPU is a matter of seconds. If it is a VMAT, the process per se is a bit longer. With the old version, it was, let's say, about 5 minutes. With the new release that is still not clinically used, a VMAT plan is done in a couple of minutes. And then there is the treatment that depends on the number of beams of arc, etc. So the measured time ranges in the clinics from, say, 12-ish minutes to 30 minutes, more or less. But depends, longer is in the trials, shorter is in the routine application. If you look at the data from Amsterdam, all their papers reports times of the order of 30 minutes, in some cases more. But for example, they acquire 3 cone-beam CTs. The real cone-beam CT, 1 cone-beam CT before treatment, and 1 at the end, because they are exploring the reliability of the entire process. Centers doing just the adaptive are in the time range of 15-ish minutes.
Something dedicated and integrated as well. So with the patient in the clinic, something completely different of our attitude up to now. You see what is happening. Please, do you have any other? Please. If I say well, Professor.
Luca and Vasilis, you said previously regarding the future what kind of evolution will happen, but let's focus on the enormous evolution in technology, hardware, software, and even in clinical workflows regarding the integration of imaging, planning, and treatment delivery. Let's put now following question, looking for the next 5 to 10 years. Are we going still to need CT scanners in radiation oncology?
Okay, Dimos, this is a very provocative question, but first let me give my personal answer as a physicist. Yes, I strongly believe in CT. We need at some level a real CT data because we need to do an accurate dose calculation. But if systems like HyperSight or whatever will be the technology of the future will be able to generate volumetric image sets at the machine with the Hounsfield unit accuracy that we need for accurate dose calculations, then probably in the RO process, the planning CT role will be diminished significantly, and we will open more and more the role for MR-only workflow or biologically informed workflows where we can feed in the process of planning information that today, honestly, we are rarely using in depth. The CT component at the machine will do a lot, and I believe we will never be able to get rid of it if we want to be accurate. But we can do a lot of integration with all the other during the process.
I think this is the main aspect. CT will live forever, but integrations are just in front of us. Do you agree with this, Dimos?
It was my second point for the discussion. We discuss about the human resources if we look to the integration technology. I don't know how the situation in Greece is. I don't know how the situation in other countries is, in Italy. But in Germany, we started a program of 2 years to educate therapists, especially for adaptive treatments, with the plan that only for the first adaptive, the physician is required, and then all the other procedures are done by specially qualified therapists.
Yes, absolutely.
This is absolutely already discussed.
Absolutely
with
true.
Please, Luca.
But for example, also Estro is moving in this direction. They recently published a position paper on the Green Journal that is promoting or defining a new profession for the RTTs. And this is certainly a road that we have to follow. It will take some time. Europe is Europe, but regulations are so different from country to country. In Italy today it would be impossible to delegate everything to a therapist. In the Netherlands, it's much easier, and both we are European. So there is also a political and legislation path to follow. But it's clear that is the way we have to go.
Very good point. And the hot point is that consuming of what? Of time, or, as you said, of human resources? Because we need a clinician dedicated. Where is the clinician? How many clinicians do we have? That's the hot point, indeed. Thank you for your question, Dimos. Do we have any other question? Well, I may have the opportunity. Do you want to add something to your lecture, Luca? I may add something like a comment. Well, learning curve for the new system, learning curve for the artificial intelligence, learning curve for the new era of stimulus radiation therapy, but there is something more than that. Something that it is really related to the clinical practice, to the routine clinical practice. Are we sure about what we believe today and what will be a clinical guideline after 5 or 10 years? No, because let me tell you something. Let's go back 10 or more years ago, when the IGRT, the volumetric CT, came to clinical practice, and then we realized that all the previous years we were sleeping like a baby at night, not aware of what we're giving as a treatment. Okay? Dimos, you know, thank you. So, what would be the future? What will be the future? Okay, learning curve for the new device, for the new system, for the new procedure. Learning curve as well as a reflection of the clinical practice. You said before about the sigmoid, about the rectal mucositis, that it came up all of a sudden of the new era of the artificial intelligence, because we focus there and we see what is happening there, because there was no way before to see what is happening there as an adaptation, as an image guide, or whatever. So I have the impression that the next decade we are going to see a lot of this problematic stuff coming to our face that we are not aware today that it will come to our face. Anybody want to add to this comment, please? So everybody has to be very, very careful of the new technology. That is my.
I totally agree, and we have a bit to change our ways of putting ourselves in the clinic. Technology is appealing, is super nice, super fancy. We can publish plenty of articles, so it's enjoyable. Absolutely. And it gives you grants, it gives you PhD students, it gives you a lot of fun in the clinics. But that is a risk as well. What we have to be very careful, and what we have to change with respect to the past, if you look at the IMRT era, we have to really generate the evidence through seriously defined and properly defined trials. And we have also to accept that maybe some of the questions will end up in a negative answer and something will not be really needed. We don't have to be driven by the technology, but we have to drive the technology. And none of us will ever lose the job, but we will lose our job if we just be the hands of the technology. We will have to continue to be the brain and to use our brain more and in a different way. But technology is helping a lot. The generation of AI-informed diagnostics. If you look at the number of screening images for breast cancer with mammography, it is hundreds of thousands, and how many clinicians do we have? So we need the technology, but then we need the way to understand what are the clinical benefits. And this is our task in the next decade or so.
A navigator, but not the captain of the ship. Do you agree?
If I may add just one phrase. In addition to the previous, education also should be affected by this technology? I mean, the new doctors, the new medical doctors, and the new operators, and the new medical physicists should be aware of all the advances and the dangers.
Again, this is an excellent point, and being also, say, involved in the academics is sometimes very difficult in the education programs to include technology, because there are commercial conflicts that you have to stay out of, and there are multiple vendors having different options and different solutions, and it's not easy to get students access to all the possible technologies. But at least from a conceptual point of view and from a say, understanding of the mechanisms, it's mandatory. In the past, we were teaching how to do hand calculations for the plants. Today, we have to teach what AI means, what a deep learning means, what unsupervised learning means, in terms of the clinical risks and the clinical benefits. I'm trying in my small educational pattern to do this, but what is missing is a formalized program. But it's coming. You know, we are slow, and the technology is faster than what we can do, but it's mandatory, absolutely.
It's mandatory because sometimes, as I said yesterday, it is very important for the medical physicist, but for the medical doctor as well, not to use this as a black box with a bottom, with an enter and something like that. But we have to be deep inside, because there is a new knowledge, and the way that we are going to use it, it is coming through the way that we know it. Because there are two things, the usage and the knowledge. Do you agree?
We have to hammer on the knowledge.
Hello, thank you very much for your talks. It's not exactly a question, it's a comment about adaptive radiotherapy. What about quality assurance? In the chain of adaptive, we didn't see the step of patient QA.
Yeah, it's difficult to do measurements because you have the patient on the couch, so everything is delegated to in silico verifications. This applies to any online adaptive mechanism. It's not only the solution that I presented today, also the MR-based have to do in silico verification. This means that you have to rely on calculation algorithms that are independent from the one you use, usage of steering files or the records of the machine to do the calculations, and in my opinion this is insufficient. It can give you the green light for the daily treatment, but what I would hardly recommend to not avoid is a real measurement process of periodic QA. Maybe you can have your benchmark patients or plants that you have to verify on a periodic, weekly or monthly process, as we did in the past, because it's really important. Said this, I have about 30 years of clinical experience and 20 plus in IMRT. I have hardly seen a QA failing for technical deficiencies of the machine or of the system. I saw plenty of QA failing because human errors or bad usage of some parameters in the planning on those kind of stuff that are more sensitive to human errors. Machines are really reliable and robust, but we are to some extent the weakest point in the chain, and we have to make some new way of QAing the a priori process and not the down the road process.
Okay, thank you.
That was a good question, really. So, do we have any other question, any comment from the audience? Okay, I think it's high time now to close this session without an artificial, but with a human intelligence, saying something like, humanity is in front of artificial intelligence, but artificial intelligence should be under the scope of the humanity. Do you agree? Thank you so much, and thank you all for being with us today, and have a nice time in Athens. Thank you so much.